Thank you. So we're going to stay outside from loading until the tech guru comes back. I think we had moved on to why you should be confident in people doing dermatologic procedures in your office or your institution. So let's get back to this is what the skin looks like. We have a atom cream or skin layer settled in. Underneath that's an epidermis, and then the dermis is this thick leather. That's what leather is, cow dermis, full of collagen and blood vessels, and the follicles actually sit just under that in the subcutaneous fat. You're just reminded here of what this part of the world. Let's start with what's called cryotherapy or cryosurgery. Probably had coding to call it cryosurgery, but it is in fact just freezing things with liquid nitrogen. In our office, we use cryo guns. You've seen those. They are about $650 for the little one, and much more for the bigger ones, but they can last for decades. They're all on grass fittings. In the absence of that, a styrofoam cup works well. If you use a wax cup, you'll freeze your hands and hold on to it. So styrofoam cup, thermos, just a little stool thermos. One of my mentors wandered around with his kids like 1965 Mickey Mouse thermos. It's if you use a cup, you need a cotton tip applicator to hold on to the nitrogen so that it freezes. I'll show you in a little video how to make a big fat Q-tip. In general, 3 quick freezing cycles, 3 long freezing cycles if the lesion is thick, and a little less if you're just on a very thin lesion. We'll show you some of that. If you wait a minute or two, the skin should start to respond to the acute frostbite injury by getting a little bit of redness and edema around it. If you don't see the redness, you probably haven't frozen it for long enough. If you see a blister, you may have overshot the nerve. And then if you're using a cryo gun, something that sprays under pressure, you really have to understand those freeze deeper and faster. So you have to think about what's underneath, especially tendons. You don't want to spray those to the eye. There's a certain amount of displacement of the air around it that can be disconcerting to patients. And the spray gun, the spray itself can freeze surrounding structures if you're in crevices, like the genital area, the groin folds, funicular folds, or ears. Excuse me while So here's the video of how to make a cotton tip applicator big enough to hold on. Don't have a cryo gun. You can use a Q-tip and a cotton ball to make a Q-tip that holds onto enough liquid nitrogen to do a cryotherapy. I just pull a little bit of it away and wrap it around the existing Q-tip, pulling as I go, just to get a little bit of cotton wool in there, like cotton candy. And then if you twist it, you still have a big flat Q-tip swirling it in my hand. Here I have a Q-tip pass around for those of you who painted it. And you can use those GIM Q-tips if you can find them. But, you know, getting things out of central supply in order to do a biopsy is just so time consuming that you're probably not going to do that. I recommend that you just order what you need and have it sitting around in a Ziploc storage bag or something in your office. If you're at a big institution, and even if you're not, I carry a Ziploc bag for help to see inpatients and just throw out everything I need to the Ziploc bag and this little carry-all. I used to carry a little tackle box. So now we're going to dip that big fat cotton tip applicator into nitrogen. I think. And then I should cuts this one. Big model is $800. So if the release the pressure on it is boiling in there, and then you can dip your wand that you just made into the nitrogen. You can see it's moving, and that means there's enough nitrogen in there for a freeze, which will be demonstrated. Trying to show you there that it's holding on to the nitrogen. So I made the mention in the video that the nitrogen is boiling. Nitrogen is about 300 plus degrees below zero. And so when it's at room temperature, it boils. And it creates this tremendous pressure, which is fun to play with, we've all seen. And in major crimes with smoking nitrogen. If you pour it in the sink and put some water on it, it's like a cauldron of smoke. But it's important to remember that if you have it in a gun, it's under enormous pressure. You can't just open the thing up; it boils over onto your hands and things. It's also important. I'll mention this in the video where I'm showing you an actual freeze. That you shake a little of that nitrogen out. Just dip it into a cup and drag it over to the patient. A few drops of that on the patient. It won't hurt the patient, but it scares them and they think they're burned, and you end up, slowing yourself down. So in my opinion, it's always better to treat something twice than it is to start a patient once. I'll show you some pictures of what can go sideways if you over freeze. So if I'm trying to treat something on someone's face like an actinic keratosis, I'll say, I'm going to try hard not to scar you. There's a risk of scarring with this procedure, but I have experience. My goal is not to make a scar; it's to make this spot go away. But I may need to come back if it doesn't go all the way. And patients are pretty accepting of that. They don't want the scar on their anything, and so it's worth mentioning. And then just if you're really going to town on some old guy who's covered in a bunch of actinic keratoses, try to be sympathetic. I'll show you a picture, but if you treat 15 actinic keratoses, that person is miserable, and they are unlikely to come back and see you. So there are better ways to treat a large number of actinic keratoses, like the type of chemotherapy, trifluorouracil cream, etc. And it is to just blast them with nitrogen until the cup is empty, or your arm is tired from doing it. It always works 3 or 4 days after you treat. So I always ask before I treat the face, always, what is your social calendar look like this week? Someone who's got a black tie affair, speaking engagement, or a sales pitch they need to make, you should not be freezing anything on their face. You are perfectly capable of freezing people's faces, so that's not the purview of dermatology. But just remember, if you haven't had something on yourself frozen, go get something frozen and then watch it over the next week. It doesn't look so good after we do this. And then you really, as I reminded you, always need to think what's underneath there. There's the thin skin on the back of the hand.
In progress.
You can rather tendon. Don't forget to stay muted. And don't get anywhere near the eyeball with any kind of nitrogen unless you're in real trouble. And then I do this all day long at a relative high speed. I do try to talk to people even briefly about the risk of a scar, because it can scar, and if they weren't warned, they would be upset about that. We have a sort of general consent form when patients come to our office that explains that procedures can cause scarring, but I try to mention it before even this line of procedure that I did literally 40 times a day. So here's a little video of me freezing this elderly man's shoulder yesterday. If you watch his baptismal wet band, see at the top there, he has a pretty good glimpse. He has 2 adjacent actinic keratoses almost stacked on each other like a snowman. So I hit both of those with my cryo gun first, and then we'll use a Q-tip in the second video. All right. So 3 quick people. 1, 2, and then you see the white cross, which is just actual frostbite. And it will slowly thaw, and that's enough for that lesion. Okay. Want to watch it again? Yes.
You have to wait between the space to thaw.
No, you don't. You want to see it start to thaw, and then you can freeze it. In the next video with the Q-tip, there's a longer period because I have to dip the Q-tip, but routinely I go 1, 2, 3. What you don't want to do is freeze to the point that the expanding frost gets bigger and bigger and bigger, right? Because you're freezing a small lesion. You don't need a ½ inch of frost around a tiny wart. But the beauty of the cryogun, as opposed to the Q-tip, is that little stream of nitrogen is extraordinarily tight and composed. And you see how close I hold my hands in that? I will frequently have my fingers right next to where I'm spraying so that I can feel if that spray is extending too far. You also saw, and I'll play it again because it's short, that I touch the lesion first to make sure I know where it is. I'm wearing a, you know, hands-free magnifier on my head and stuff, but it's important that you have a sense of where you're freezing. It's why I also hold that tip of the freezing gun so close to the patient. You don't need to blast at distance, and in fact, the cold dissipates very quickly at distance. So you put the gun nozzle right up next to what you're trying to do. And when we teach residents and students how to do this, it's important that they hold the gun really directly above the lesion. Yes.
And you would count that as three.
That was a 3-3 site. I just put that in my EMR. It said the lesion was frozen with 3-3 site. Until you get comfortable with this procedure, I think it's okay to let it fully come on, do it again. That's fine. I've got 30 years of shooting a crowd in people, so I can pretty much go boom, boom, boom. It's fine to let it fall between. You're not going to see the redness and the swelling until the lesion has a few minutes to get a dentist, right? The biology here is it takes time to recruit, you know, inflammatory fluids, and the tissue damage is really immediate. And you know that if you nick your own finger with a crab, it hurts, and I killed my fingertips, you know, 3 or 4 days later because I caught a little too much blast. But let's watch that again. Just again, watch that I push against the patient with my thumb to be sure I'm in the right spot. I do not normally wear gloves to treat things in my office. I have a genetics disease that gives me what I can consider to be ugly hands. It's been sure when I'm a dermatologist. And I didn't want that distracted from the video. So that's why I'm in gloves. You do not need gloves to A, touch patients, or B, use a cryo. I'm stroking the lesion to be sure I know where it is, and the gun is right next to 3 quick people, and you see me make a figure of 8. And then you see the white frost, which is just actual frostbite. And it will slowly thaw, and it's enough for that lesion. And I frequently tell patients that I'm frostbiting. They'll say, oh, you're going to burn it up. It's important that they don't think that's a burn. It's a thermal injury, but it's not hot. It feels hot. If you have this done, it doesn't feel cold. It feels painful and almost shock-like in its pain injection. So here's the same procedure done with a cut-to applicator, something you're far more likely to have access to than an $800 cryo. So with the nitrogen-filled Q-tip, we just touch it till it's white with frost. See how necessary it is? And I'm going to put this in here and show you that I have to kind of shake it off. You don't want it dripping on everything. And there's the third time's a charm on that actinic keratosis. So A, that's a smaller lesion than on the gentleman, and B, I think you can see, show it again, that I have a push nitrogen-filled Q-tip. We just touch it till it's white with frost. We touch it again, and I'm going to put this in here and show you that I have to get it. So if it's a wart and it's a big wart, you might just leave the nitrogen on there and get the whole thing to turn white. If you're doing what I'm doing on your thin 80-year-old skin on a thin actinic keratosis, you're going to be treating a wart for a long time before you get the thing frozen. It's okay to leave a fair amount of nitrogen in the reservoir and tip the cotton-tipped applicator vertically so that the nitrogen begins to almost drift down into a thick wart. And we'll talk about warts in just a second. All right. Here's rethinking things. Here's what not to do. Oh, actually, I'm sorry, on the slide ahead. Here's the little seborrheic keratosis on this patient's arm. And the day later, it's kind of blistered up in red. Remember to think of that if you're treating faces. And 4 weeks later, it looks great. It doesn't look great 2 days later, and it doesn't look great 2 weeks later. So when patients start to ask, say, oh, in about a month, this thing should be done. If you set that expectation, they won't call you on day 6 and say, well, I still have my lesion. You don't need those calls. So this person on the left with the hands, too many lesions treated. That's going to incapacitate that woman in terms of doing dishes or, using her hands function. They're blister filled, they hurt. This person on the right got frozen for way too long and a big blister formed. The blister can readily be popped. I just explained that they can sterilize a needle, pop the side of the blister, get the fluid out, and stick a Band-Aid on it. Fluid can't be accumulated. Do not tear the roof of a blister off. The skin makes a wonderful dressing, a better dressing than any Band-Aid ever was. So leave the blister roof intact, but just drain the fluid out. And if you cover it with a little pressure downward in the bandage, it won't reaccumulate. And here, this child was frozen into a crevice. Remember, we talked about avoiding that. And all of that erythema that's extending, which could easily be mistaken by urgent care as, a cellulitis in the hand, is actually just thermal injury from the spray going the wrong way into that crevice and getting driven down onto the hand. Really be careful with folded skin areas. And then I just wrote OA because that's someone's face. There's 4 good sized blisters on there. So just, it's always better to bring the patient back and treat something a second time than it is to leave a mess. Let's talk briefly about warts because they're so common and they're so easy to treat. They're caused by HPV, and nitrogen does nothing to kill HPV. Yes, sir.
How quickly do you bring them back? So if you're going to schedule something, if you're going to
like 3 to 4 weeks. You need time for the wound underneath underneath the lesion to heal and for the lesion to come off. And it varies wildly in people how long that can take. And so if you bring it back at 2 weeks, a lot of times they're still going to lose the lesion that's going to heal off. It just hasn't done so yet. So I do 3 or 4 weeks for fallback. And I usually just say a month and they lose track of time and they get better. Most patients that you'll encounter in elderly people have had things frozen. They understand how this works. But if it's a first timer, I think it's always worth talking a little bit about what your expectation is. I explain HPV biology to patients every time I treat a wart. These warts just make us look stupid. We cannot kill a wart. Duct tape works as well as anything. Nothing works better than 22%. In huge studies of all modalities, the best we can do is 22%. So if you don't talk patients through that, they'll say, well, I've had this wart treated 93 times and it's still there. Well, that's on you. We're really waiting for your immune system to wake up. The medical right immune system, burglar breaks into your house and steals your iPad. You want your burglar alarm to go off. But if a leaf lands on the roof, you don't want the burglar alarm to go off. And this is basically a leaf on the roof. The HPV does nothing except surgically. It does nothing to the health of the patient. The immune system just doesn't really want to deal with it. Moreover, if your cutaneous immune system is lit up all the time looking for wart virus, you end up with eczematous disorders and a bunch of rashes. That's what the immune system does. The skin is caused rash. So really, you're trying to injure the skin enough to draw an immune response. That's what you're doing. And I explain, just like I am to you guys, to my patients every time I stop and they show me their work. And have a little science lecture, and I explain about HPV. Yes.
Is HPV vaccine going to do anything to the incidence reports?
It's only those serotypes that cause cervical cancer currently, but I always take this opportunity to talk about getting vaccinated, being HPV vaccinated. So I say, after I get my science lecture about, houses and break-ins, your immune system and nitrogen being useless against the wart virus and bleach being useless against the wart virus, I say, really, there's this great vaccine against wart virus, and have you had it? And they keep pushing the age range up, because of course, if you have a cancer vaccine, perhaps we should be using more of it because of it. It's a great opportunity. I see it all ages, so it's a really nice opportunity to encourage parents to get their kids HPV vaccinated. There's so much actual craziness about vaccines in general, but this vaccine in particular, because it's associated with sexually transmitted disease, and they're supposed to get it at age 11, and parents just really out of it. So when the kid has a wart on her hand, I say, oh, this thing we treat with a vaccine to get your immune. I talk about the serotyping, but nonetheless, it opens a door that we should be open much more.
Okay, just a point of
Yes.
clarification. If somebody already has that serotype, vaccination doesn't clear the virus. Is that correct? Is there any evidence?
The vaccination reduces the cancer risk even if they already have serotype. But it doesn't necessarily work. Again, if you think about the HPV virus on the surface of human skin lives just through the dead layer in what's called the surrounding granules, the last layer of the infection. So really, you don't want a lot of surveillance of that. We would be allergic to everything. We have poison ivy to everything. We had that kind of answer. So all you're doing with nitrogen or any other modality for that matter is causing enough injury to try to drag some T-cell response up there and to get some immunity. Yes.
Candida antigen injections helpful.
Yes, we use a lot of Candida. The question was whether Candida antigen injection is useful. Almost everyone in the world who doesn't have active untreated HIV is immune to Candida. It's what causes diaper rash. They'll get immune early. And so you can inject pieces of that antigen right into the wart. It hurts like hell to put a needle into the wart. And don't do that on the soul if you've got some real consent. It causes a very similar amount of inflammation. It takes a few more days, again, because you're dragging T cells from deep in the lymph nodes up to the skin surface. But it can blister and it reaches profoundly. That's all a good sign. You have to have the right patient. They don't do that in children. I hardly use nitrogen in children. That's good. And when I use it in children, I use a cotton tip applicator, as I showed you, and I hand the applicator to the child and cut the nitrogen, and I let them put it on. And they'll freeze their work way longer than they would let me freeze it. They're sort of fascinated by watching it, and they get distracted intellectually by what's happening. That I've just given them all the power in the office, and there's this smoking thing in their hand, and so they'll really freeze the work pretty hard if given the chance. And if you have a patient who's freaking out that it hurts, just hand them the tip and say, "Well, here you do it," and it really takes the feeling of powerlessness and I'm being hurt by someone else totally away. And again, they'll freeze their word. Sometimes I just, okay, that's enough. It is kind of fascinating stuff. You took the smoking and you could not understand. So I think I covered everything on that slide. Don't forget to mention vaccination. So a few pearls. This kid on the top, 95 wards in a 3 square centimeter area. You don't have to treat all those. In fact, you'll just make a big awful blistered mess. If you can treat the 4 or 5 biggest warts, all the same viral type, once the person gets immune, all the warts will go away. So you see those, we call them mosaics, this kind of nice Grecian tile pattern here. You really don't have to treat every one of these. And I also explain that. I'm only going to treat the biggest ones. We call them, controversially or biased mother warts. There. But really it's one word giving rise to all these other ones. In a kid, they skin their knees all the time. The virus just spreads. In women with warts on legs, they tend to spread them by shaving. A lot of genital or groin warts are spread by shaving. Hair removal methods. When you injure the skin, it lets the virus spread around more easily. So these are in children are often in places of trauma. Don't blister the sole of the foot. I almost never use nitrogen on the sole of the foot. It hurts too much, and a patient can't walk for 2.5 weeks because your gross wart that you can't guarantee them getting rid of needs to see the risk-benefit ratio a little differently than you do it. You really don't want to incapacitate people, so we use overnight, long-term top the use of workroom. Dr. Schiff workroom, we broke the counter. It's perfectly acceptable method. Compound W doesn't work. W is for water. It's in a water basin. It just basically evaporates. The Dr. Schiff product is in an acrylate base that sticks a little longer to the skin surface. This is why duct tape works for warts, is that it sits there and causes essentially some necrosis of the skin. So salicylic acid plasters work as well as just plain old duct tape. So moving briefly, we'll try to get out of cryotherapy onto biopsy here. Again, this is an older person's hands. I've never had probably even a drop of sunscreen applied to the back of the hands. And if you go trying to kill all these, you really harm the patient. It'd be far better to treat this person with topical 5-fluorouracil on the back of one hand, BID for 2 weeks, let that heal, and then treat the other hand. Don't incapacitate 2 hands with aggressive treatment. These 2 little AK on the nose, however, are perfectly reasonable size for 2 quick freezes after you discuss, 3 freezes on each one with 2 lesions is what I meant to say. Only after a discussion, the fact that you're not going to look very good for days to weeks. These are considered pre-malignant, and a code for them is different. I have a last slide is about how to code all these procedures. If something's thick, you can rub, you saw me rub my finger on those AKs before I touched the patient with nitrogen. If they're thick and hard, you have to make sure they're not squamous cell carcinoma. So something that's powering up with a big cutaneous horn on it, it's like a thorn counters can come freeze that. It's hard to freeze through that much keratin to get to the base of the lesion, but B, you really are burden falls on you to prove that that's not the same cancer that needs more aggressive surgical treatment. If the lesion fails after nitrogen, meaning you did it properly and it peeled off, but it immediately regrew, those patients need to have a biopsy as well. And again, I've had 30+ years of experience, and when someone comes back and says, we froze this last time, I always biopsy because it's often still an AK, but I don't want the patient to get lost in health and have an enlarging spleen. They just say, oh, that she froze it and it can come off. It should come off, and if it comes off and regrows, you need to biopsy. So let's talk about biopsies. This is a really easy procedure that I'm happy to have you in my office and do a few of these a day until you feel confident about it. But really, you should practice and get good at this because this is a very simple, very quick way to get a lot of information. If you're looking at something that's close to the epidermis, meaning it's scaly, it's plainly visible, brown, biopsy brown things, we'll talk about that. Shape biopsy is all you need. You don't need a bunch of sutures. You don't need to, call central supply for stuff that you don't have in your office. But if you're trying to look at deep structures like the base of the hair follicle to figure out what's in the hair falling out, or palpable purpura, which is down in the dermis, remember palpable purpura comes from dermal blood vessels, you generally want a pinch biopsy because you need deeper structures to help your pathologist figure out what you want. It's okay to do a shave biopsy and have the pathologist say, I need more tissue. But again, you'll get so good at shaves that 90% of biopsies will do a shave biopsy. And then when you really want to cut something all the way out, you need an excision. And we have an excisional bunch of slides. I think that's probably not what you came here to learn today, but I have access to that and we can put that in. That's in the talk. You may not have to report. So these are pictures of basal cell cancers. This is near the eye, but it's on the orbital rim. So if you can see my arrow, I'm perfectly happy to biopsy this. When something's way up here, I send them to oculoplasty. Once you're up at the lash line, that's not skin anymore, that's eye. But way down here, this is still skin. And I say way down here because you should think of it as way down. Another basal cell. So basal cells come from the basal or bottom layer of the epidermis, which is non-keratinizing tissue, and they make these smooth, shiny, curly things that you recall, I'm sure. Squamous cell carcinomas come from the upper levels of the epidermis, and those are keratinizing tissues, so they make all this heavy scale, rough and hard. It can be hard. For instance, in this lesion on the right is the traumatized seborrheic keratosis, or this squamous cell carcinoma, and I biopsy plenty of seborrheic keratoses in a week, and it's okay to do that. Not okay to say, oh, that's probably not, and leave it there, right? So it's okay to biopsy a benign lesion and get a half report back that says that was a benign lesion. Patient feels better, you feel better. Don't try to talk yourself out of something that looks funny. And again, I biopsy SKs when I know I'm not sure. So if you're biopsying a rash, these scaly red rashes at the surface of the skin are perfectly amenable to a shave biopsy. Now, the one on the right, you might think is palpable purpura. But if you touched it, it's not terribly palpable, it's got some scale on it, it's okay to shape biopsy. These are kind of crappy cartoons of shape biopsy, but if you see that you can get down in through the dermis and not be down in the subcutaneous fat, which is yellow, not blue, and get what you need to send to a pathologist. Sometimes I'm so worried about scarring of, for instance, a nasal tip or an eyebrow or something, that I do a really biopsy. I'll just call back and says, "You gotta give me more than that." I send a bunch of stratum for me and expect that the pathologist can talk to you about what's under there. So, and that's okay too. It's okay to err on the side of caution. It's okay to get a path report that says go get more, or a path report that says that's a benign lesion. It's better than losing the patient follow-up and missing something. So if it's a single lesion, I usually try to get the whole lesion. If you think it's a melanoma, you should definitely try to get the whole lesion. If it's huge, a 2 centimeter plaque, it's fine to just biopsy at the edge. You don't need to make a 2 centimeter hole in someone to get a diagnosis. If it's over any part of vital structure, it's okay to just take it apart. It's not over the vital structure. Like, the cartilage of the ear, you don't want to get down in the cartilage of the ear. It doesn't heal well on the skin. There are 3 questions in the room, so I'm going to pause and answer them.
You mentioned it's a melanoma, you want to get all of it. I think that's scares a lot of us.
Yes.
Are we going to cut some metastases or some bad outcome if we do a shape and we don't get it all?
Yeah, so let's talk briefly about that, although that is on an upcoming slide. We use the depth of melanoma to prognosticate survival and outcomes and treatment plans, all based on the depth. A deep melanoma is, 2 millimeters. So you probably safe to do what we call a deep shape biopsy, which I'll talk about in a second. There is absolutely no evidence that transecting a melanoma leads to metastasis, and that's been actually very well studied in retrospective studies where tumors were transected and the patients followed for years and years and years. So let that fear leave you immediately. It is, and I'll talk about this in an upcoming slide, far better to get a lesion off in your office if you think it's a melanoma than it is to have that patient leave, reschedule for another time, get scooped, and not come in. So I don't ever let a melanoma walk out of the office. A lesion I think might be a melanoma, I always biopsy it. And I don't worry so much about getting it all as I just get it all. And I have transected melanomas with deep shades, and you go back and take more, and it's all okay. Yeah.
Is there a traditional teaching that I'm misremembering of not shading pigmented lesions for fear that it's melanoma and you mess up the
Yes.
the depth of the lesion?
And that was bad. So the question was, should you not shade a pigmented lesion? You can confidently shade pigmented lesions. I do it all the time. You just want to think about what you're doing. You want it taken off. And I've gone in and taken a shape biopsy and seen black pigment at the base left behind on the patient. It's not in my little razor blade, and just taken a deeper shade, gotten all the pigment. 2 specimens on the same model, and I write to the pathologist and say, transected at first pass, second pass, and if they can stack those little specimens and figure out how people do not let a patient you think has a melanoma walk out of the office. That's my humble opinion. Now you're at an institution where you can call derm and say, hey, we're sending Mr. So-and-so over here. You need to biopsy it. But out in practice, you can't do that. If you tell the patient, oh, I'm worried about this lesion, I've got to go see the dermatologist. Even if you call me and I'm patient in 2 days later, there's a fair number of people who will just freak out and then we lost a follow-up, and then they could die from the melanoma, and their lives could have been saved if you just felt confident enough about a biopsy. So again, practical person that I am, I want you to let go of fears that you're going to screw it up. You're not going to screw it up. I screwed it up by transecting a melanoma, and I just go right back with my blade, second deeper pass, and everything works out. They don't get metastasis, and they get the right diagnosis, and then they get treated properly.
What would I have to see on a pathology report to make me feel like I don't have to send this positive cancer diagnosis to a dermatologist? I can't imagine a scenario where I'd be like, oh, yeah, Definitely got it all. You're good.
So the pathologist, yes, sorry, I'm gonna repeat the question. The question is, what should the pathology report say on, malignant skin lesion that makes you confident that you don't need to do more? So if I have a small basal cell skin cancer and I start, and I will show you a picture of a video of doing a shake biopsy. I start at the edge, outside the edge of the visible lesion, and I go past the other side of the visible lesion. And the pathology comes back and says basal cell carcinoma, negative margins. That's a cured basal cell carcinoma. Okay, that patient doesn't need Mohs surgery. That patient doesn't need to come back from electrodesiccation and curettage procedure with me. They don't need a topical immunotherapy. That's one way of treating skin cancer, by the way. That's aniquimod. Like, they don't need more therapy because pathology report says you got it. They do need to have that lesion looked at again in 3 to 4 months to make sure that there's clinical regrowth. But they don't need that lesion retreat. So that happens all the time. We take a thin biopsy of what we think is a basal cell. It comes back as a basal cell carcinoma, negative margins. We just set the patient's appointment for 2 months for a reach. Okay. The other thing you need to know about skin cancer, and sort of jumping all over, but I like to answer questions as they come up, is that the patient with a single basal cell is at risk for a lot for skin cancers. And so they might show you a tip of their nose, and you might take your little biopsy of the tip of the nose, but it might be hiding melanoma on their back that they didn't mention. They don't even know it's there. So the other part of bringing the patient back for us is to screen the entire integument for other tumors. And then it's not in my slides, I'm not talking about skin cancer specifically, but patients with what we are calling now epidermal skin cancers instead of non-melanoma skin cancer are at risk for other tumors. And so I talk to patients about their smoking habits, their risks of other solid tumors, because patients with non-melanoma skin cancers or epidermal skin cancers are at risk in general from more tumors, including breast, colon, lung, boulders. So we spend a little time with those people afterward, not just saying, oh, this is stupid, this is skin cancer, I got it all. But what else are you doing that's bad for you? And you can colonoscopy and you do recent mammogram. Again, I may be a little bit of an outlier because I'm an internist at heart and an externist by practice, but you know, those things matter. And if you're not being holistic about what the skin is representing, we're missing a lot of stuff. Oh, I want to go back to this just briefly. If you're biopsying rash, try to find something the patient has torn to shreds with their fingernails. That frequently will mean biopsying the back, but that's great because they won't care so much about a little scar there. Try not to biopsy things that are in tattoos. The pathologist clearly sees all that tattoo pigment. It looks very different than melanin, but it does make it harder to see on a biopsy. And then look for some kind of characteristic lesion. And I'll frequently ask the patient, what's the newest spot you have? What's the oldest spot you have? And then you try to choose one that doesn't look like either of those. You really want something that's acutely inflamed, but not torn to shreds like iron. But you need to do it with skin biopsy. You need to think of the order of how you do these things. I can send the patient in their skin, numb them up, take it off, send it to pathology, start the bleeding, and put wound dressing on it. And that's all in this slide. I didn't realize how late in the game we are. This is my little tray. We just have a nail stand always set up by my assistants with all this stuff on it. So there's a local anesthesia cotton ball for alcohol. I know you probably have jets alcohol here. That's fine too. There's a Q-tip that will go in this little bottle of aluminum chloride, which is dirt cheap. We buy it by the gallon and refill these little bottles. This is a pathology bottle, so that's another Band-Aid. This is a Q-tip that's sitting in Vaseline, which is a wound dressing, pair of gloves, Persona blade, which we'll talk about, and a little pile of gloves. So when I'm doing this, I see a patient every 10 minutes. So I don't sit down long form to consent them. I say, no, I think this should be biopsy. There's a risk of pain, bleeding, scarring, and infection when they do a biopsy. But I'm really not going to be able to tell you whether this is something to worry about or not unless I take it off. Leaving the benefit of the biopsy as the last thing I say, rather than pain, bleeding, scarring, and infection. That's my favorite phrase is, we do a biopsy, then we'll have a diagnosis. Yes,
If you use plain lidocaine or lidocaine with FP.
yep, I'll go over that. The question was about the lidocaine. So let's get to that slide. We use 1% lidocaine to epinephrine up to 100,000, and we add a little bicarb, 8.4%, which radically decreases how much these shots hit. It's very common for patients to say, I had no idea you even numbed me up, and I'm already putting a Band-Aid on, which I'll show you in the video here. So that's a nice trick, is just a little 8.4% bicarb added to your syringe. 1 to 10 is a little easier math. This whole thing that you should never put epinephrine on the fingers, toes, feet, his nose is just wrong. There's an enormous amount of literature that says that's perfectly safe, especially if you're 100,000, and really reduces bleeding. So when patients say, I can't have epinephrine, I'll use plain Lido, but it's much more difficult. It bleeds like hell. Most patients aren't allergic to epinephrine. They've had a rapid cardiac response to the procedure they're having, and they've been told, oh, it's the epinephrine. We have to give an IV infusion of epinephrine to raise the heart rate. And the volumes used for skin biopsy are just safe. They're safe even at the tips of fingers and tips of noses. So don't ignore that teaching for many years ago as well, and just move on. I never let the patient see the needle. It's important that they don't. Too many patients are absolutely paralyzed by fear of needles. So I'll keep it way down low under the table. I'll come around the back of their head just to avoid the tell them to their eyes. Don't want them to see the needle so that they don't panic. We use a 30 gauge needle, which is almost painless. You want to try to get a little bit under the lesion. That's where your blade's going to go instead of the top of the lesion, where you're going to be in the dermis. So get the medicine into the dermis. I just use what we call talk anesthesia. I talk almost the whole time. How are the kids? What are your travel plans? And I don't say, okay, I'm about to give you the shot. Okay, here we go. You just keep going, and the patient won't feel. And here's a video footage of that. We use the double edged persona blades. We buy them 100 for 15 to 30 bucks. I think the last time we paid they were $20. You can break them in half to save money, but these are very wobbly blade, and I never liked that. My partners used to do that to save money, but it wasn't worth the money to me. The more you flex the blade between your third finger and your thumb, the deeper the shade. So when you're thinking about it, you really want to flex the blade to get deep under that thing. And you always want to saw back and forth, just like when you're cutting a steak. You don't want to shove the blade forward. The blade works by movement, just like a steak knife. And you'll cut that out with little saucer shape. A couple warnings: people with little thin skin, it just acts like wet tissue paper in your shape biopsy. It'll just go on for 2 inches well outside the anesthesia area, unless you're confidently stabilizing it with your other hand. It is literally like wet toilet paper. You can practice on a good right tomato. The skin of the tomato has a little give like the dermis does, and then the tissue underneath lets you get that sawing motion down. And when I give a workshop, just buy a crate of tomatoes and I draw a bunch of practicals on these, and people are paid to practice starting before the black sugar mark and ending after the black sugar mark to show the whole melanoma got taken off, so to speak. And then don't ever throw a piece of cheese. I put skin tags in bottles and put them in bottles. It protects me. It's not necessary on a skin tag. I know what a skin tag is, but a pathology report that says it was a skin tag is really valuable in the patient's chart. And if someone has 30 skin tags and they're type 2 diabetic armpits, I put them all in one jar and just tell pathology skin tags, right armpit, skin tag, left armpit, separate specimen bottle. And they just mount them all on a block and then analyze it. But again, pathology is there to protect you as well as help the patient. Never tell a pathologist rule out lesion. That's like rule out chest pain. It's a symptom. That's not a diagnosis. So we try to be more specific, and I say things like this: a 54-year-old white female sun worshipper. It's important for the pathologist to know what she's standing in their office. There's a jet black mole on sun exposed skin. I think it's a melanoma. It's fine. They don't tell the patient I think it's a melanoma, but I tell the pathologist I think it's a melanoma. And then they can smile and separate. Don't be afraid of being wrong. We use aluminum chloride 20%. It's to the desiccant. The surface area wound has to be dry for the desiccant to work. Moncel solution is much more of an actual clotting agent, but it can tattoo the skin, so we literally never put that on the face. Sorry. Pressure alone just stops the vast majority of bleeding. You know, you have to hold the pressure while you chat with the patient about vacations and grandkids and that kind of thing. And really, you can't look every 2 or 3 seconds. That's not constant pressure. That's what patients do when they say, "Oh, I have pressure for 5 minutes, doctor." They were looking every 2 or 3 seconds. So that just keeps the blood flowing. Aspirin causes pretty dramatic delayed bleeding. I will usually wait several seconds. I won't say minutes, but I will watch them for quite a little bit of time while I get the Band-Aid ready, that kind of thing, to make sure they're not bleeding. Patients don't know that aspirin is an anticoagulant. So when you can't stop the bleeding, just say, "You're on aspirin." And it really can do skin biopsies in anyone on a blood thinner. You just need to be ready for bleeding. I do biopsies now that in 3,000 platelets because everyone else is too afraid to do that. It just takes a lot of time to get bleeding to stop when you're at platelets. But you guys can confidently do them down about 20,000. Here is a quick video of me doing a shape biopsy. That's all. Let me get more noise here. Sorry. People and then pinch your skin between the fingers and give you the little injection. So this is the pinch. 1, 2, 3, stain. 1, 2, 3, stain. Not 1, 2. We just push it in slowly. It shouldn't be too painful. And then I'm going to stop pinching. Never. Good. So just a few more. So I'm raising the weld curve. 2, 3. You can see that it's raised up. Around here. Just go back and forth. That's the way I'm putting it fingers. And I keep my index finger free in case I need it to hold on to that tissue. Consistent. And then we stop the bleeding a little bit nice like that. And then I always wait a few seconds to make sure it's done bleeding. It's not just clattering. That's my clattering and just showing you. You wouldn't necessarily have that in the room, but that's a hot wire clattering. It's like 12 hours to wait places. And then she got a Band-Aid on and she's done and she can't believe it's already over. So the salient features of that video, raising that wheel and pinching the skin helps lift the skin away from the underlying structures, the non-skin foreheads. There's not much under there. But if you're, you know, at the temple or the eyebrow or the penis, you know, you're going to want to lift that skin away from important underlying structures. And I would normally be talking to her not about the biopsy, but I'm trying to teach in this video. So I talk that much. I'm just not talking about the biopsy. When I'm doing it on a patient who's not being videotaped. And I have this lady's consent to show her face, but I would not identify her. Then I hand patients this typed up wound care sheet that says, "Please wash your wound with soap and water after 24 hours and keep a little more Vaseline on a Band-Aid and keep it covered throughout the wound healing process." And at the bottom it says, "Please call the office in blank." We put a date in there. We now call our patients directly and don't ask them to call us. Touch biopsy and move it quickly for the last few seconds here. Used for things like hair loss, these thick tumoral dispersed cutaneous T-cell lymphoma. We do that in things that are scaling like hair loss. You generally want about 5 millimeters to help the pathologist. Choose a representative site. Same consent. Well, now you're going to put in sutures. When you bring the patient back for suture removal, I like to see those patients to tell them what the biopsy showed, so I code those visits as the diagnosis found on the biopsy, not as a suture removal, right? If I'm seeing the patient face to face, that is a billable visit. If the patient just needs suture removal and they didn't need a discussion of what pathology showed, the nurse does that in the office, and that's not billable. Suture removal included in the price of the biopsy originally billed. And there's a little global period for that. So if you're meeting with the patient to discuss the biopsy, please use the code of the biopsy diagnosis. Otherwise, you always want to use, and I'm going to skip around here a bit, biopsy codes, which will say things like neoplasm undetermined behavior. So there's a melanoma, and I wrote excisional biopsy, but a deep shade would be acceptable on that lesion. This is erythematodosa, and it occurs in the fat, so you have to go down deep. Trying to wrap this up really.
Deep shave means hits back. But
Deep shade just means it's thick. They could be. You don't have to hit your fat, but you want to get down under there. You don't have to excite the melanoma, but you do want to try to get the whole thing and the depth. And then you see my statement. I feel strongly that it's better to get it off than to lose the patient to follow-ups. Far better, life-saving, in fact. So don't be afraid to do a biopsy with a shave if that's all you do. I do it all. Here's the codes, the code neoplasm of undetermined behavior or rash unspecified. And then afterwards, you'll code correct diagnosis of the patient needing more treatment when you're meeting them face to face to talk about it. These are all the codes for freezing actinic keratosis, which pay better than benign lesions for some reason, even though it's the exact same skill set to do it. If you're treating benign lesions, like inflamed SKs, there's 14 of them bundled together, and then if you do more than 15, we've done too much as we discussed, but that's a separate code. You don't code 1 to 14 and more than 15, you just code more than 15. And special sites in the penis, vulva, and external ear are give you more reimbursement. And oddly, the penis pays more than the vulva. Are there other questions? Yes.
so in terms of further management after biopsy, and say if it turns out to be basal cell or squamous cell, if there's clear margins is done, you don't need ED and C or anything like that.
If the pathologist has said that the margin is negative, you are finished, not with the patient, but you're finished with that process. Okay. If the pathologist says squamous cell carcinoma with positive mutagens, that patient needs more care. So if you have a good dermatologist in your community or in your institution, you can call and say, hey, I got this CAT report and here's what it says, and it's on the guy's back. It's on the guy's back, and you know how to do an elective excavation in keratosis, you can do that. It's on the guy's face, it's in a needle browser. We refer those for primary facial lesions and recurrence. And your pathologist is your best friend, just like your radiologist is your best friend. They're better if you give them more information. They love to interact with you. And so you can call them and say, okay, this is moderate atypical melanocytic nevus. I have no idea what to do with this. What do I do? And they'll tell you. Sometimes a CAT report will say, we feel better if you keep back a lot more of this atypical mole that is not a melanoma. And they will usually say very clearly why it's not melanoma, but you can also call me or your favorite dermatologist and say, I don't understand this pathology. Perfectly okay. We know, as your dermatology colleagues, that there aren't enough of us, so I routinely help my peers out in the community manage rashes and things after they've gotten them out. Yes.
What's your favorite absorbable suture for smaller excisional biopsies?
What was my favorite absorbable suture for smaller excision biopsies? I don't use absorbable suture for biopsies. Suture, quote, dissolving suture, absorbable suture takes about 3 months to absorb. And it tends to leave unclear scars than nylon. So nylon and proline's softer and easier to tie off, but cheap nylon is mostly what I use. Pretty cool. It comes out in one of the slides in your slide deck says how long to keep sutures in. And we just let our nurses do that. I don't see most of my suture removals. Our nurses do that. But if you want to see them, it's better to use nylon suture and remove the suture at the proper time, 5 days for the face, up to 14 days on the back. And it is to leave a suture in that's kind of quote dissolved. Patients don't take great care of their wounds, even with written instructions, and the skin grows over the suture and it becomes a big awfulness. So I use absorbable suture if I'm doing a deep excision. I have to close the lower layers of tissue, and I mostly use undyed white pulp.
There was one question about apple cider vinegar and warts. Is that something that-
It works as well as it works as nitrogen, it works as well as. There's nothing special about that. In fact, in children, you can just let them make a little concoction in the kitchen. They just put it stuff in it, then use it on and it works as well as anything. We are only waiting for the insects to wake up to the work. That's all. That's all for the rest.